Hello friends, today I am going to discuss with you about another important topic, complications of lithotomy position and its prevention. As you know, being an obstetrician and gynecologist, we use lithotomy position in our labor ward and operation theater. So it is very important to know complications related to lithotomy position and what measures we can use to prevent these complications. So what is lithotomy position? Standard lithotomy position requires the patient legs to be separated from the midline into 30 to 45 degree of abduction, with the hips flexed until the thighs are angled between 80 and 100 degree. The patient's legs are placed into stirrups with the knees bent such that the lower legs are parallel to the plane of the torso. This is the lithotomy position. So, what postoperative complications could occur after lithotomy position? Neurological complications, acute compartment syndrome, venous thrombosis, and rhabdomyolysis. Now, neurological complications. Most common lower extremity neuropathies associated with procedures in the lithotomy positions were common peroneal 81%, sciatic 15%, femoral 4%. Less commonly injured nerves include obturator nerve and femoral cutaneous nerve. Positioning related nerve injuries in the lithotomy position have been attributed to overflexion of the hips and knees, which cause stretching and compression of the nerves. So, common peroneal nerve is the most superficial when it crosses the head of the fibula. It may easily be compressed and injured at this point by direct contact of the leg against an immobile hard surface. Therefore, padding of the lateral leg supports during positioning for lithotomy procedure is recommended. Injury to the peroneal nerve most commonly manifests as foot drop, resulting from an inability to dorsiflex the foot. In addition, patients may experience numbness of the lateral aspect of the lower leg and the dorsum of the foot. Now, excessive stretching of the sciatic nerve by overflexion of the hip and extension of the knee during establishment of the lithotomy position or by shifting of the patient during the procedure may result in injury. Excessive hip flexion in the lithotomy position may compress the nerve as it passes through the sciatic notch, thus potentially resulting in ischemic neuropathy. The potential sequelae of sciatic depends on the location of the insult along the course of the nerve. Injury to the thigh portion of the sciatic nerve, for example, results in difficulty with flexion of the leg, whereas disruption of the tibial nerve abolishes the ankle jerk reflex. Similarly, hyperabduction of the thighs with external rotation of the hips may lead to injury of the femoral nerve, secondary to ischemia from compression of the nerve beneath the inguinal ligament. Now, nerve injuries during procedures in the lithotomy position may be minimized by careful attention to proper patient positioning, including padding of exposed peripheral nerves, avoiding unnecessary tension on the hips and knees, by checking to see that the muscles of the lower extremities are not taut after the lithotomy position is established, and minimizing operative time. Modification in stirrup design have also been proposed to help minimize the complication of lithotomy position. These are stirrup boots, which are basically used in the lithotomy position to minimize nerve injuries. But these stirrups can lead to acute compartment syndrome, which I am going to discuss. Now, acute compartment syndrome happens when pressure increases within a specific area of your body. This increase in pressure disrupts blood flow, which can hurt the function of your surrounding tissues. The lithotomy position increases your risk of acute compartment syndrome because it requires your legs to be raised above your heart for a long period of time. Acute compartment syndrome is more common during surgeries lasting more than 4 hours. To avoid this, your surgeons will likely lower your legs carefully every 2 hours. The type of leg support used can also play a role in increasing or decreasing compartment pressure. calf sports or boot-like sports may increase compartment pressure, while ankle sling sports may decrease it. These are ankle slings which are used. They decrease the risk of acute compartment syndrome, but on the other hand, they increase the risk of neuropathies. The lithotomy position is known to decrease venous blood flow and predispose to lower extremity venous thrombosis. Measurement of their ankle arm index and ratio of their ankle systolic pressure compared to their brachial blood pressure preoperatively immediately after being placed in the lithotomy position revealed significant drops between preoperatively and immediately after being placed in the lithotomy position. In view of this pressure drop, standard lithotomy stirrups such as those usually utilized for OB procedures should be used with caution for procedure requiring prolonged lithotomy position. Now, rhabdomyolysis is a complex medical condition involving the rapid dissolution of damaged or injured skeletal tissue. Rhabdomyolysis with secondary acute renal failure can occur with both the lithotomy and exaggerated lithotomy position. Rhabdomyolysis and acute renal failure can develop in such operative positions even in the absence of compartmental syndrome, and that duration of surgery is the most important risk factor for such complications. So we should be careful regarding duration of surgery in a lithotomy procedure to prevent such morbid complications. Thanks for watching. If you like my video, please subscribe to my channel and click the bell icon for more updates.